Good day, everyone. I am Raymark Picayo from 3ABA Psychology A. So today, I will be reporting the other type of depressive disorder, which is the premenstrual dysphoric disorder. Premenstrual dysphoric disorder has been recognized since ancient times. However, before it became a premenstrual dysphoric disorder, as an original term for this disorder, PMDD was came from different term throughout the years. In 1930s, Arte Frank coined the term premenstrual tension syndrome. By 1950s, it is changed to the simpler term premenstrual syndrome or PMS, which means a condition experienced by some women before menstruation that may include tiredness, irritability, anxiety, depression, headache, and stomach pain. Premenstrual tension syndrome and premenstrual syndrome is just indifferent in term, but they are in fact the same thing. Nevertheless, the concept of premenstrual disorder has become very broad and covers the condition that vary from very mild primary physical symptoms to the more severe syndromes involving mood and behavior that are associated with impairments and psychological functioning. By the late 1970s and 1980s, many investigators were focusing on the mood and behavioral changes during the menstrual cycle. Investigators who were interested in treatment of severe premenstrual changes tended to adopt unsuggested criteria and method. They also tended to select women for study. And these investigators serve as consultant to the DSM task force when the third edition of the Diagnostic and Statistical Manual of Mental Disorder, or DSM-3, was being revised. In 1987, criteria for late luteal phase dysphoric disorder, or LLPDD, a classic biopsychological disorder resulting from complex interactions of biological, psychological, socioeconomic, and cultural forces on women, that were proposed and published in the appendix of the diagnostic in the DSM-3 by the early 1990s on the fourth edition of the DSM. The name late luteal phase dysphoric disorder changed to premenstrual dysphoric disorder, or PMDD. Premenstrual dysphoric disorder, or PMDD, is a condition in which a woman has severe depression symptoms, irritability, and tension before menstruation. The exact cause of premenstrual dysphoric disorder was not fully understood, but researchers believe that PMDD is caused by being very sensitive to changes in hormone levels. Re- Recent research suggests that PMDD is associated with decreasing levels of estrogen and progesterone hormones after ovulation and before menstruation may trigger symptoms. Serotonin, a brain chemical that regulates mood, hunger, and sleep, may also play a role. So the criteria for um, diagnosing or diagnosis for PMDD. So here are the important criteria that I put in the PowerPoint. So you can refer to this and five for more criteria. So in criterion A, in the majority of menstrual cycle, at least 5 symptoms must be present in the final week before the onset of the menses. Criterion B, one or more of the following symptoms must be present. 1. Mood swings. 2. Marked irritability or anger or increased interpersonal conflicts. 3. marked depressed mood. 4. Marked anxiety. Criterion C, one or more of the following symptoms must additionally be present to reach a total of 5 symptoms when combined with symptoms from criterion B above. 1. Decreased interest in usual activities. 2. Difficulty in concentration. 3. Easy fatigability. 4. Change in appetite. 5. Sleep disturbance. 6. Overwhelmed or out of control. 7. Physical symptoms. Note, the symptoms in criteria A to Z or to C must have been met for most menstrual cycles that occurred in the preceding years. Criteria D, clinically significant distress or interference with work, school, social activities, and relationship. Criteria E, the disturbance is not merely an exacerbation of the symptoms of another disorder. Criteria F, criterion A should be confirmed by prospective daily ratings during at least 2 symptomatic cycles. Criteria G, the symptoms are not attributable to physiological effects of substance or another medical condition. So the prevalence of PMDD, so the 12 months prevalence of premenstrual dysphoric disorder has been estimated at 5.8% based on a large study from Germany. Prevalence over 2 menstrual cycle found 1.3% of menstruating women with no disorder. Also, 1.3% for women whose symptoms met diagnostic criteria and had no co-occurring mental disorder. The prevalence of premenstrual dysphoric disorder symptoms in adolescent girls may be higher than that observed in adult women. Risk and prognostic features. So there are two risk and prognostic features, which are the environmental factors and genetic and physiological. For environmental factors, it includes stress, history of interpersonal trauma, and seasonal changes. And for the genetic and physiological, so it's stated there that there is no study have examined heritability in premenstrual dysphoric disorder specifically. For diagnostic markers, daily ratings of severity of problems and the visual analog scales for premenstrual mood symptoms have undergone validation and are commonly used in clinical trials for PMDD. The premenstrual tension syndrome rating scale has a self-report and an observer version, both of which have been validated and used widely to measure illness severity. So the differential diagnosis for PMDD. So we have premenstrual syndrome. So premenstrual syndrome differs from premenstrual dysphoric disorder in that premenstrual syndrome does not require a minimum of 5 or more or nor mood-related symptomatology, and it is generally considered to be less severe than premenstrual dysphoric disorder. Dysmenorrhea. Dysmenorrhea is a syndrome of painful menses, but dysmenorrhea begins with the onset of menses, whereas premenstrual dysphoric disorder begins before the onset of menses. Bipolar disorder, major depressive disorder, and persistent depressive disorder. Many women with either naturally occurring or substance or medication induced bipolar or major depressive disorder or persistent depressive disorder believe that they have premenstrual dysphoric disorder. However, when they tried symptoms, they realized that the symptoms do not follow premenstrual pattern because the onset of menses constitutes a memorable event. They may report the symptoms occur only during the premenstruum or that symptoms worsen premenstrually. Use of hormonal treatment. Some women who present with moderate to severe premenstrual symptoms may be being or using hormonal contraceptives. If such symptoms occur after initiation of exogenous hormone use, the symptoms may be attributable to the use of hormones rather than to the underlying condition of premenstrual dysphoric disorder. Another medical condition. Women with chronic medical condition may experience symptoms of premenstrual dysphoria. As with any depressive disorder, medical condition that could better account for symptoms should be ruled out, such as thyroid deficiency or anemia. So, what are the possible treatment for PMDD? So, clinicians advise the client to take antidepressant. So, it is to help them manage the brain's serotonin levels. Also, they are advised to have dietary changes, such as cutting back on salty, fatty, or sugary foods and caffeine. And also for those um, women who are taking pills, so they are advised to use hormones birth control that has trispyrinone and ethinyl estradiol. So they're also advised to take over the counter pain medicine to ease the pain that they are um, suffering, and also to have regular exercise to improve their mood, and stress management tools such as deep breathing and exercise. So that's it, or that's all with the premenstrual dysphoric disorder or PMDD. So let's proceed to another type of depressive disorder, which is the disruptive mood dysregulation disorder or the DMDD. So a new diagnosis in the field of mental health. Children with disruptive mood dysregulation disorder or DMDD have severe and frequent temper tantrum that interfere with their ability to function at home, in school, or with their friends. So it was put into place due to the overdiagnosis and treatment of bipolar disorder on children up to 12 years of age. So the diagnostic criteria for disruptive mood dysregulation disorder or DMDD. So criteria 1, severe recurrent temper outburst manifested verbally and or behaviorally. Criteria 2, the temper outbursts are inconsistent with developmental levels. Criteria 3, the temper outbursts occur on average 3 or more times per week. Criteria D, persistently irritable or angry most of the day, nearly every day, and is observed by others. Criteria E, criteria A to D have been present for the 12 or more months. Criteria F, criteria A and D are present at least 2 or 3 settings in home, school, and peers, and are severe in at least one of this. Criteria G should not be made for the first time before age 6 or after age 18 years. Criteria H, the history of observation. The age at onset of criteria A to E is before 10 years. Criteria I, there has been or there has never been a distinct period lasting more than 1 day during which the full symptom criteria except duration for a manic or hypomanic episode have been met. Criteria J, behaviors do not occur exclusively during an episode of major depressive disorder. Criteria K, symptoms are not attributed to physiological effects or a substance or another medical or neurological condition. So the onset of DMDD must be before age 10 years, and the diagnosis should not be applied to children with a developmental age of younger than 6 years. Diagnosis should be restricted to age groups similar to those in which validity has been established, which is 6 to 18 years old. Children with disruptive mood dysregulation disorder are at risk or at increased risk to develop unipolar depressive and or anxiety disorder in adulthood. For the risk and prognosis factors, temporal. So children with chronic irritability typically exhibit psychiatric history. In such relatively extensive history of chronic irritability is common. So many children with MDD have also met criteria for ADHD and for anxiety disorder. For some criterion for depressive disorders may also be met. So that's why it is important if we are or to diagnose a certain disorder. So it is common that a certain disorder met some symptoms of the other disorder. So that's why it is important to look at the severity of the symptoms and for the duration to identify a certain disorder that a client experience. For environmental, disruptive family life, such as psychological abuse or neglect, parental psychiatric disorder, limited parental education, single parent household, early trauma, death of a parent, parental grief, divorce, and malnutrition. So these are the factors that may cause the DMDD for children. So if the children experience parental psychiatric disorder or having negligence with the family or having a trauma from a death of a parent or a family member. So this may cause a child to have a DMDD. And for the genetics and physiological. So a family with history of depression may be at risk of DMDD. For differential diagnosis, bipolar disorder. Bipolar disorder. So, discrete mood episodes of mania and depression, lifelong episodic illness can be diagnosed at any age but rare in childhood. Peak onset in 20s to 30s, and psychosis may be present. While in DMDD, severe, not episodic irritability does not develop into bipolar disorder associated with severe outbursts or tantrums, cannot be first diagnosed before 6 or after 18, not associated with psychosis. So, these are the difference between bipolar disorder and MDD. So, for the attention deficit or hyperactivity disorder or ADHD. So for ADHD, so contains neurodevelopmental disorder, normal emotional age, impact learning, and structured environments most. While DMDD depressive disorder, mood expression is significantly abnormal, not episodic, impact on environment, and associated with dangerous behavior. For intermittent explosive disorder, intermittent explosive disorder, sudden range or anger outbursts are triggered by identifiable stressor, reaction for exceeds stressor, not due to thorough anxiety or behavioral disorder. While the MDD, mood expression significant abnormal, irritability is a core feature, impact the environment and associates with dangerous. For comorbidity, so rates for comorbidity in DMDD are extremely high. This appears higher than any other pediatric mental illnesses, with the strongest overlap with oppositional defiant disorder. The range of comorbid illnesses appears particularly diverse also. So, what are the possible treatment for a child experiencing disruptive mood dysregulation disorder? So, clinicians um, advise to have psychotherapies such as cognitive behavioral therapy or the CBT, dialectical behavior therapy for children, or the DBT-C, and also parent training. So, in order for the parent to have a idea or knowledge on how to treat and how to care and handle their children having DMDD. And also, they are advised to take medications such as stimulants and antidepressants such as SSRI and atypical antipsychotics or risperidone when other approaches have not been successful. And also the antipsychotics, and also they had advised to take anticonvulsants and also the sleep aids. So that's all for disruptive mood dysregulation disorder or DMDD. So let's proceed to another type of depressive disorder, which is the depressive disorder due to another medical condition. So, in order for us to know if a person is having a depressive disorder due to another medical condition, so let's look at the diagnostic criteria. So, criteria A states that a prominent and persistent disturbance in mood that predominates in the clinical pictures and is characterized by depressed mood and diminished interest or pleasure in all or almost all activities. Criteria B states that there is evidence from the history, physical examination, or laboratory findings that the disturbance is the direct pathophysiological consequences of another medical condition. Criteria C, the disturbance is not better explained by another mental disorder, example, adjustment disorder with depressed mood, in which the stressor is a serious medical condition. Criteria D, the disturbance does not occur exclusively during the course of delirium. Criteria E, disturbance is causes clinically significant stress or impairment in social, occupational, or other important areas of functioning. So, coding note, the ICD-20-CM code depends on the specifier. So, um, we already know how or what is the importance of this code. So, in order for us to know and have a glimpse of other explanations about this disorder from other references or from other institutions. So, code FO6-31. So, with depressive features. Full criteria are not met for a major depressive episodes. And FO6 Point 2, with major depressive-like episodes, full criteria are met except criterion C for a major depressive episode. FO6.34, with mixed features, symptoms of mania or hypomania are also present but do not predominate the clinical picture. So, coding note, include the names of the other medical condition in the name of the mental disorder. So, example, depressive disorder due to hypothyroidism with features. So, for the associated features, a causal relationship to another medical condition based on best clinical evidence is the key variable in depressive disorder due to another medical condition. The listing of the medical condition that are said to be able to induce major depression is never complete, and the clinician's best judgment is the essence of this diagnosis. There are clear associations as well as some neuroanatomical correlates of depression with cerebrovascular accident or the CVA, Parkinson's disease, Huntington's disease, traumatic brain injury, or the TBI. So, among the neuroendocrine conditions most closely associated with depression are Cushing syndrome and hyperthyroidism. Autoimmune disorders such as systematic lupus erythematous and deficiencies of certain vitamins such as vitamin B12 have also linked to depression. And currently, there is support for a direct pathophysiological mechanism for depressive disorder and focal lesion, such as CVA, TBI, neoplasm, affecting certain brain regions. Parkinson's disease, Huntington's disease, hypothyroidism, Cushing's syndrome, and pancreatic cancers. So, these are the disease that are linked to um, depressive disorder due to another medical condition. So if you have this kind of medical condition, so it is said that it is possible that you will have a depressive disorder due to this medical condition. For development and course. So following stroke, the onset of depression appears to be acute. Depression occur within a few days of CVA in the largest case series. However, in some cases, onset of depression is weeks to months following the CVA. In the largest series, the duration of the major depressive episode following stroke was 9 to 11 months on average. So, with Parkinson's disease and Huntington's disease, depression often precedes the major motor impairments and cognitive impairments associated with each condition. This is more prominently the case of Huntington's disease, in which depression is considered to be the first neuropsychiatric symptoms. So, this is some observation and evidence that depression is less common as a neurocognitive disorder due to Huntington's disease progresses. So, in some individuals with static brain injuries and other central nervous system diseases, mood symptoms may be episodic or recurring over the course of the disorder. So, in Cushing syndrome and hypothyroidism, depression can be an early manifestation of the disease. So, in pancreatic cancer, depression often precedes other features. So, for the risk and prognostic features, the risk of acute onset of major depressive disorder following a CVA within 1 day to a week or of the event appears to be strongly correlated with lesion location, having greatest risk associated with left frontal stroke, at least risk apparently associated with right frontal lesion in those individuals who present with this of the stroke. In an individual with Parkinson's disease, early age at onset, greater burden of motor symptoms, and longer duration of the disease have been associated with depression. Risk of depression after TBI has been associated with female gender, prior depressive disorder, early psychiatric symptoms following injury, lower brain volume, and unemployment. So, this may be the possible factors for someone to have a um, depressive disorder due to medical condition. So, for the sex and gender related diagnostic related issues. So, women may be differentially higher risk for developing depression in the setting of cardiovascular disease, particularly post stroke. For diagnostic markers, diagnostic markers pertain to those associated with medical condition. For example, steroid levels in blood or urine to help corroborate a diagnostic of Cushing's disease, which can be associated with manic or depressive syndromes. For association with suicidal thought or behavior. So there are no epidemiological studies that provide evidence to differentiate the risk of suicide from a major depressive episode due to another medical condition compared with the risk from a major depressive episode in general. There are case reports of suicides in association with major depressive episodes associated with another medical condition. So there is a clear association between serious medical illnesses and suicide, particularly shortly after onset of diagnosis of the illness. Thus, it would be prudent to assume that the risk of suicide for a major depressive episodes associated with medical conditions is not less than that for other forms of major depressive episodes and might be even be greater. So, for differential diagnosis, a depressive disorder not due to another medical condition determines whether medical condition accompanying depressive disorder is causing disorder depends on. So, the absence of an episode of depressive disorder prior to the onset of the medical condition. The probability that the associated medical condition has a potential to promote or cause a depressive disorder, and a course of the depressive symptoms shortly after the onset of worsening the medical condition, especially if the depressive symptoms remit near the time that the medical disorder is effectively treated or remits. Medication-induced depressive disorder. An important caveat is that some medical conditions are treated with medications, for example, steroids or alpha interferon that can induce depressive or manic symptoms. In these cases, clinical judgment based on all the evidence in hand is the best way to try to separate the most likely and or the most important of two etiological factors. In, for example, association with medical conditions versus substance and induced syndrome. So it is very important to know if the depressive disorder is due to another medical condition or it is caused by a substance induced syndrome, because another medicine that um, a person take to treat his disease may cause or induce depressive disorder. So it is very important to distinguish which is the cause of the depressive disorder. It is by medical condition or it is by a substance um, take by a person. So the delirium and major or mild neurocognitive disorder. So, for this, a separate diagnosis of depressive disorder due to another medical condition is not given if the depressive disturbance occur exclusively during the course of delirium. However, a diagnosis for depressive disorder due to another medical condition may be given in addition to a diagnosis of major or mild neurocognitive disorder if the depressive disturbance is judged to be physiological consequence of pathological process causing the adjustment disorder. So, adjustment disorder. It is important to differentiate a depressive episode from an adjustment disorder, as the onset of the medical condition is in itself a life stressor that could bring on either an adjustment disorder or an episode of major depression. The major differentiating elements are the pervasiveness of the depressive picture and the number of quality of the depressive symptoms that an individual reports to demonstrates on the mental status examination. The differential diagnosis of the associated medical condition is relevant but largely beyond the scope of the present manual. For demoralization. Demoralization is a common reaction to chronic medical illness. It is marked by a sense of subjective incompetence, helplessness, and hopelessness, and a desire to give up. It is often accompanied by depressive symptoms such as low mood and fatigue. Demoralization typically lacks of anhedonia associated with depressive disorder due to another medical condition, and individuals will generally find pleasure in previously meaningful activities and be able to experience moments of happiness. So that's all for this depressive disorder due to another medical condition. So summarize. So depressive disorder um, can be triggered, or a person can have a depressive disorder due to under medical condition because um, if that person having a medical condition, they struggle to treat themselves, and they become depressed because they think that they are um, incapable of doing things that they did before because they have a medical conditions, and they are not having the same physical um, strength that they have before when they don't have a medical condition. That's why those people who are having medical conditions, as mentioned above, or has a high risk of having depressive disorder because of their medical conditions. So now let's proceed to the suicide. So what is suicide? Suicide is a death caused by injuring oneself with intent to die. So every suicide is a tragedy that affects families, communities, and entire countries, and has long-lasting effects on the people left behind. Suicide occurs throughout the lifespan and was the fourth leading cause of death among 15 to 29 years old globally in 2019. So for statistics, it is stated there that more than 700,000 people die due to suicide every year. 77% of global suicide occur in low and middle income countries. The lifetime risk of suicide among people with untreated depression ranges from 2.2 to 15%. And depression is present in at least 50% of all suicide. So those suffering from depression are at 25 times greater risk for suicide than the general population, according to American Association of Suicidology 2014. 50 to 80% of older adults who die by suicide have been shown to have major depression. Only one third of those with depression seek help. Look at on your screen. So this is the suicide rates around the world. So estimated rate of suicide per year per 100,000 population in selected countries in 2019. So the data shows that most women to have or to commit suicide is from Russia, and was most women to have commit suicide is from South Korea. So these are the countries that have a high risk or high cases of suicide. So including Russia, South Africa, South Korea, United States, Japan, India, Germany, United Kingdom, Brazil, China, Spain, Italy, Indonesia, and Turkey. So these countries are having a high risk of or a high suicide cases. So that's why it is important to um, be aware of the people around us, and also um, to spread awareness to all people kung ano ba ang importance ng mental health, and also para malaman din nila kung bakit mahalaga na ma-diagnose ng isang tao kung meron ba talaga siyang disorder o meron siyang depression, so that mm, mm, ma-treat siya ng maaga, and also hindi na siya mag-lead into suicide. So, the next data shows the suicide rates of the Philippines from 2010 to 2019. So data shows that in 2011 there is a high suicide cases recorded compared from the other year. So the data shows a fluctuations. So tataas, bababa. So this data was present in July 2022. So it is the latest data from the suicide rates from the Philippines from the year 2010 to 2019. So what are the risk factors for suicide in a person who is experiencing depression? So the first is impulsivity, history of aggression, substance abuse, of course, and chronic pain. Diagnose physical illness such as stroke, heart disease, or cancer. Social isolation or withdrawal and or access to lethal means of suicide. So, what are we going to do to prevent suicide? So, these are the protective factors. First is effective clinical care for mental and physical needs, care for substance use disorder, support from ongoing medical and medical health relationships, skills in problem solving, conflict resolution, and nonviolent ways of handling disputes. Cultural and religious belief that discourage suicide and support instinct for self preservation. Restricted access to lethal means, connectedness to community, school, family, and friends. Get the treatment you need, establish your support network, and remember, suicidal feelings are temporary. So these are the following um, protective factors that we're going to do or apply if you are having a friend that have suicidal thoughts, or to give your friends to avoid committing suicide. And also, let's help together to spread awareness to other people and to give learnings and knowledge on how to prevent suicide so that we could be able to lessen the suicide case in our country and to the world. So that's the end of my report, and these are my references. Thank you very much for listening, and I hope you learn from my report. Once again, good day.